Hello everyone, welcome to your lecture on the sensory system. We're going to focus on eyes and vision. These are the objectives that we will be covering in this lecture. This section over here is the basic anatomy and physiology of the eye and vision. Please review this. If you do not remember it from your anatomy class, these are just different functions, the function of, a vision, the functions of the eye, things like that. And then we in this lecture we will talk about the assessment management and diagnostics of vision problems. So when we're doing an assessment, we want to get their personal history, living conditions, independence, occupation, any allergies, family history, nutritional history, any history of eye trauma, right? Do there any use of protective eye equipment, any risky behaviors like, some kind of sports that can, maybe expose them to damage of the eyes, right? Your physical assessment will include all these things. That includes symmetry, the structure of the eyes, and some of this we covered when we talked about health assessment. So please, go back and you can review that. This is, the Snellen chart, and this is the Ishihara color vision. This helps for, to see if the patient has any, difficulty recognizing colors, identifying colors, right? And then this is for visual acuity. We use this. And then you want to check, physically, the eyebrows, eyelashes, eyelids, any discoloration, lesions, or drooping, which can signify maybe a stroke. You want to check the iris, the color, symmetry, size, shape of, which we do with the pen light, right? We try to measure what the size of the iris is. Then you want to check for your 6 cardinal positions of gaze, right? This helps to, assess extraocular muscle function for especially cranial nerves 3, 4, and 6, right? Diagnostic tests usually include, a CT to evaluate like the vessels, nerves, any abscess, foreign bodies. Or sometimes they get an MRI, patients can get an MRI, sometimes a ultrasonography, especially if they want to check for cataracts, any retinal detachment or hemorrhage in the eye. And sometimes they'll get a radioisotope scanning to detect tumors or ocular melanomas. The diagnostics is the slit lamp testing, which is a routine eye exam. It helps to diagnose cataracts, conjunctivitis, glaucoma, macular degeneration, and any foreign bodies in the eye. Also, patients with, certain eye disorders, their intraocular pressure testing needs to happen regularly and make sure it's not increased. Corneal staining test. This is used to identify any foreign body or scratches on the cornea, right? Then fluorescence angiography, fluorescein angiography to determine any retinal circulation, to determine how is the blood circulation in the retina, to detect like diabetic retinopathy or retinal, hemorrhage, macular degeneration, or tumors. Surgical management, there are different ways, if they have cataracts, and there are different surgeries that can be done to help them out. And one of the most most common ones, I should say, is the LASIK surgery. They basically they use a special instrument, use of a laser through a special instrument, and to help clear out their cataracts. And we want to make sure that the patients are wearing protective goggles. People often are unaware of the injuries that they can sustain with their everyday activities, right? Especially patients who are, have occupations where maybe they have like sparks, like, going into the eyes, or chemical splashing, or they're playing sports, So we want to make sure that to prevent any damage to the eyes, they know to wear protective glasses when they're doing that. Even as nurses, like when you go into like a, airborne precaution room, we wear protective goggles, right? Or if you're going to go do wound care and, things might splash on you, then, you can wear protective goggles. And then when they're out in the sun, we need to encourage patients to wear sunglasses to protect them from, ultraviolet rays. And we also need to encourage them to do regular eye examinations. Eye symptoms that if you see these in patients and they require further assessment include sudden loss of vision in any part of their visual field. If they tell you that, oh, I can't see anymore, I just was able to see a few seconds ago and now I can't see, that's sudden loss of vision. That needs further assessment. That can be very serious. Sudden onset of pain in the eye, just sudden, right? They didn't have it and all of a sudden they have eye pain. Flashing lights, present, like they were fine and then all of a sudden they have flashing lights. That could be a sign of retinal detachment, right? So physical trauma or injury to the eye. We want to see if they're, if they had any trauma, we want to assess their eyes and follow up on it. Constant tearing of the eye with or without photophobia. We want to, check that out. Why is it that they're constantly tearing? Some age-related changes, as seeing that we're focusing on the older adult, include pupils become smaller, less responsive, loss of lens elasticity, and then you have gradual yellowing of the lens, deposits in the vitreous humor, like floaters, normal expected process of aging. Conjunctiva are more susceptible to chronic inflammation because the eyes are very dry, because they have, changes in hormones. And so the tear glands and the conjunctiva might lose the ability to efficiently lubricate the eye, right? When your eyes are dry, your eye automatically lubricates it, by, through tears and stuff. But with elderly people, there's a decreased function of that. Arteries and veins of the retina can become narrower with age and can reduce blood flow, and so they become less responsive to light reflex. Eyelids lose elasticity and tone. It can cause drooping and, decreases their visual fields. And when they're not able to see, there's that chance, of falling. So let's talk about a few eye disorders, and how we can assess and manage them. The first one, the main visual acuity disorders that you will see are myopia, hyperopia, presbyopia, and astigmatism. These are extremely important for you guys to remember. Just saying, please review these and remember these. Right? What is myopia? It's heredity. It's hereditary, environmental. For example, reading in dim, it can be caused by reading in dim lights, excessive amounts of close work, right? Clinical manifestations would be near objects are more clear than distant, and blurred vision for distant objects. So at close, they can read clearly, but distant objects become blurred. That's myopia. Hyperopia, is caused by heredity and age, right? Distant objects are clear, but near objects are, blurry. So there's a difference. Myopia is where blurred vision happens with far objects. Hyperopia is when they happen with near objects. Then you have presbyopia. Now this is a normal part of aging, right? Vision change around middle age, inability to focus on objects held close, right? Where you can't focus, things look a little blurry, right? Then we have astigmatism, which is also hereditary. It can be caused by trauma, genetics, diabetes, chronic eye rubbing, right, can also cause astigmatism. So in astigmatism, objects near and distant are blurry. You'll notice the patient squinting a lot. Sometimes you even see that in kids. You'll see them, like the kids who watch TV a lot or use their phones or tablets a lot. They start to squint their eyes a lot, right? You'll know, they'll complain of headaches or blurry vision. So medically, we want to make sure we maximize sight corrective lenses. Like, you want to make sure that they have corrective lenses by regular eye exams, things like that. Surgical management, as we mentioned earlier, these are the different options we have, LASIK being the most common one. Then for nursing management, what do we want to do? We want to treat provide individualized care based on the patient, its expectations, age, and personal circumstances. And the different nursing diagnoses could be the following here. Interventions, we check vital signs, we check for eye changes, we check diagnostic results, we check what are the age-related considerations, because remember we said there are certain things that are age-related that we want to check. Right? Ensure that the patient wears corrective lenses, provide adequate lighting. We want to teach them about wearing protective lenses when they have risky, occupations. We want to teach them to report any visual changes or chronic headaches, post-op, providing them post-op, instructions and the care that they need if they did get surgery to correct their eye vision. Then the way we can evaluate this is that the patient maintains optimal vision and they've avoided complications such as falling or further, worsening of their sight. Here are some test your knowledge questions. Please go ahead and test your knowledge. And we will discuss the answers in class. Conjunctivitis, right? What is the pathophysiology? What is this? This is also known as pink eye, right? It's basically infection in the eye. It can be viral. Viral is the most common conjunctivitis, right? Then you can have bacterial, chlamydial, or allergic, conjunctivitis as well. Like people who have allergies, seasonal allergies, they're exposed to the allergen and the eyes get pink and they start rubbing them. Or they can have a bacterial infection as well. Risk factors, poor hygiene, right? They're not washing their hands. They're not, we have to teach them to avoid touching their eyes all the time. Diagnosis is based on the history, clinical manifestation, and physical exam. Medical management is that we treat the cause of the infection, right? If it's viral, if it's allergic, we want to, take away the exposure to allergens. If it's bacterial, then they might get antibiotics. Right, so these are the different types of, conjunctivitis and the different signs and symptoms that you will see with each of these and the treatments. And if you notice, allergic, we use topical steroids. Bacterial, they're going to use antibiotic ointments. We want to make sure that the patient knows how to put those drops in their eyes. Chlamydial is, systematic antibiotics for a month, right? And then viral is cold compresses, lubricants, ocular decongestions, and hand hygiene. Very, very important. So to provide nursing care to them, we want to check vital signs, eye appearance, diagnostic results, age-related considerations, interventions, administer medications as, and eye drops or whatever is, ordered. Make sure you provide comfort care, help them and teach them about hand hygiene at home, completing their course of antibiotics, follow-up care, how to instill the drops in their eyes. These are all extremely important. Here's another question. Next, let's talk about cataracts. Cataracts are characterized by the opacity of the lens, right? It's the leading cause of blindness in the world. It causes blurred vision or double vision. Risk factors include, the elderly, right? Family history, race and ethnicity, chronic disease, obesity, hypertension, smoking, alcohol, environmental factors such as, exposure to UV light or lead exposure. Now, surgical removal is done when the vision impairment interferes with daily activities. That's when surgery becomes a necessity, right? When you're not able to perform your daily activities. So the clinical manifestation, the early signs are blurred vision, decreased color perception, and photophobia. Late signs include diplopia, that's double vision, right? Reduced visual acuity, progressing to blindness. Clouded pupil, progressing to a milky white appearance. As you can see in the previous picture, you see that milky white appearance, right? Medical management, it's usually diagnosed through an ophthalmoscope exam, a slit lamp biomicroscope, keratometry, or a scan ultrasound. The doctor will do a visual acuity check. They'll do a surgical removal of the opaque lens. That's a retinal detachment is a risk when that's the case. And then they put on a corrective lens, as you can see the picture down here, So what are our nursing plan and interventions? Pre-op, we want to demonstrate and request return demonstration of eye medication installation. This is extremely important. We want to make sure the patient understands and knows the technique to put in their eye drops. It's just very, very, very important, right? We want to develop post-op teaching plan for the patient. We want to teach them not to rub or put pressure on the eye. Now, this is after cataract surgery, right? We want to teach them to wear glasses or shaded lens when, during waking hours, and eye shield when they are sleeping, right? And avoid lifting objects more than 5 pounds, bending, straining, coughing, because all these things can increase their intraocular pressure and it can damage their eye, right? We need to maintain that IOP within a normal limit for the patient, right? We want to make sure that they take a stool softener if they're straining with their stool, because we don't want them to strain and then increase that IOP, right? Avoid lying on the operative side. If the eye surgery was in the right eye, then avoid laying on the right side. Avoid water from getting into the eye during showers, right? Report signs of increased IOP and infection, for example, pain and change in vital signs. After the surgery, the lens is gone and fall prevention becomes a priority. This is a question. Please go ahead and answer that, and we'll discuss the answers in class. Glaucoma. This is when the patient's intraocular pressure is greater than 21 millimeters per mercury, leading to gradual painless vision loss and can lead to, blindness. And remember, glaucoma is painless. That's a characteristic of glaucoma and identifying sign. Right? It's the second leading cause of blindness in the United States, and it happens in both eyes. If you notice, I even bolded that. Occurs bilaterally in those with a family history of the condition and primary open-angle glaucoma. So it will happen in both eyes for those people. The aqueous fluid is inaccurately drained from the eyes and is generally asymptomatic in the early stages. You don't really notice it in the early stages, and it cannot be cured but can be treated pharmacologically and surgically. So there is no cure for glaucoma, right? The risk factors again include race and ethnicity, right? Family history, age greater than 60 years, diabetes, hypothyroidism, myopia, medications such as excessive use of antihistamines and anticholinergics can also cause glaucoma. So the different types, we have primary open-angle glaucoma, also known as acute glaucoma or narrow-angle glaucoma. We have normal tension glaucoma, which is also known as low tension or normal pressure glaucoma. Then we have secondary glaucoma related to eye injury and inflammation, advanced cataracts, diabetes, and chronic steroid use. So these are the different types of glaucoma. And remember, the two identifying signs are increased intraocular pressure, being bilateral in these patients' family history, or with primary open-angle glaucoma, and being painless. These are important for you to remember. So with glaucoma, what is the nursing assessment? We want to check for early signs. What is that? IOP greater than 22, right? Or 21 to 22. Decreased accommodation and focus. Late signs include decreased peripheral vision bilaterally, seeing halos around lights. That's also an identifying, characteristic of glaucoma, right? Decreased visual acuity. Not correctable with glasses. Even if they wear corrective glasses, it still have decreased visual acuity. Headache and eye pain causing nausea and vomiting, right? And that especially happens in acute close-angle glaucoma. How do we diagnose it? Through a tonometer, we measure, the IOP is measured. Then the doctor might use an electric tonometer to detect any, to detect drain aqueous humor, because when you take out the extra aqueous humor from there, then that can decrease the intraocular pressure. Or they can do a gonioscopy. That's a direct visualization of the nerve. So interventions include administering eye drops as prescribed, orient the client to surroundings, because now they have vision problems. We don't want them to fall. So if they're in the hospital, orient them to the surroundings. Elevate the head of bed to 30 to 45 degrees. This helps to prevent increased IOP. Extremely important, right? Elevate the head of bed to 30 to 45 degrees. What do we educate the patient on? Adherence to eye drops. It's very important for them to use those eye drops regularly to prevent blindness, right? Vision is already lost, cannot be restored. They need to know that it's not curable, right? Teach the proper eye drop administration, safety measure to prevent injuries, for example, removing throw rugs, making sure there's adequate lighting, not drinking late in the evening because then they might have to use the bathroom and they might trip at night, right? So we want to also teach them to avoid activities that increase intraocular pressure. These things include exertion on their bodies, right? Pushing, heavy lifting, shoveling, right? Emotional upsets. When they're emotionally distressed, that can increase IOP. Coughing severely, excessive sneezing can also increase IOP. Wearing restrictive clothing, like a very tight collar, tie or belt or girdle, can also increase IOP because it increases the pressure of the circulation in the eyes, which is their IOP. Straining and at stool and being constipated, especially in older clients, we want to encourage them to take stool softeners. We don't want them to strain because that will increase their IOP. Planning and interventions for the non-seeing blind client. So this is the patient who's already lost their vision and they're blind, legally blind. On entering the room, make sure you announce your presence. Address the client by name. Do not touch the client unless they know that you are there. Like, don't go in the room quietly and touch them on their back because that will scare them and startle them because they can't see. Right? On admission, make sure you orient the client to their surroundings, like call light, chair, bed, TV, telephone, everything that they need to know because they're in a new environment now, right? Guide the client when walking, help them, assist them with their ambulation. Walk ahead of the client and put their hand in the bend of your elbow. That's the safest way, as I showed you earlier too in the previous PowerPoint, how to ambulate the client. Describe when you're walking any narrow passageways, stairs, curbs, and clients. If there's this, stairs coming up, warn the client, describe the environment as you're walking to the client. Always raise the side rails for newly sightless clients. If they just, lost their vision, then make sure the side rails are always up. Make sure the post-op eye patches are on, right? Assist them with meal enjoyment by describing the food and its placement, right? For example, a face of a clock. You can say, okay, your protein, your meat, chicken is on, at 3 o'clock, there's a chicken, and this kind of uses the face of a clock to describe their plate. When administering medications, inform the client of the number of pills, tell them how many pills they're going to be taking, and give only half a glass of water. This way, they're already blind, so if you give them a full glass of water, they might not be able to coordinate things and they might spill it. This is another question. The next path of, disorder we're going to talk about is macular degeneration. So this is it's age-related, and it's a disease that gradually destroys sharp central vision. So it affects the macula that's responsible for central vision. So remember, macular degeneration is your loss of your central vision, right? Dry macular degeneration is the most common. It's light-sensitive cells in the macula start to break down. This causes a blurred spot in the center vision. It gradually gets bigger and darker, and it takes up much of the central vision, and they can't see centrally. It can turn into what? Macular degeneration. There are 3 phases: early dry, intermediate dry, and advanced dry macular degeneration. Wet macular degeneration is when abnormal blood vessels start to grow under the macula, and that leads to that causes the damage to the macula very rapidly with the wet macular degeneration. So risk factors, modifiable, is hypertension, high cholesterol, obesity, smoking, decrease in zinc blood levels, and decreased zinc levels. These are, modifiable risk factors, right? Non-modifiable are age, greater than 60 years, family history, females, race, especially it's common in, whites. So clinical manifestations include straight lines that appear distorted. If you see here, like these are straight lines for normal vision, and a person with macular degeneration will see it like this. They literally will see it like this. It's right in the central vision. Absent or distorted central vision, dark blurry areas, or whiteout on center vision, diminished or changed color perception. So medical management is pupil dilation to examine the back portion of the eye, tonometry, fluorescein angiogram, laser surgery, photodynamic therapy, injections into the eye, right? The cues that we're going to recognize, things that we need to look for, are early detection to decrease progressive decrease in vision, right? Regular eye checks, vital signs, check for increased blood pressure, educate the patient about it, to maintain control their blood pressure. Physical assessment, if they see any, do you see any with the ophthalmoscope? The doctor will look for any yellow spots, abnormal vessels leaking in the back of their, in their eye. We need to check for visual acuity, loss of sharp central vision. Onset may be gradual. This is important for you to remember. That's why I bolded it, right? It's extremely important about macular degeneration because we're talking about so many different eye disorders. It's important to look for the identifying characteristics. And for macular degeneration, it's age-related, right? It happens with age. It's loss of sharp vision, central vision. Onset may be gradual with age, right? So these are important things to remember with macular degeneration, right? And then the actions, we want to make sure we have safety precautions, provide follow-up instructions to the patient, and make sure that they get regular eye exams and get these things checked, right? We want to teach them about the disease. We want to teach them, help them find community resources that can help them now that they have, vision problems. Here's another question for you. One more. And diabetic retinopathy, right? It's a progressive complication of diabetes. When we talked about diabetes, we talked briefly about diabetic retinopathy, damage to the retina, right? Because of uncontrolled blood sugars. This and diabetic retinopathy can happen with elevated blood pressure and blood glucose, which damages the retinal capillaries and alters blood flow. It leads to areas, of ischemia. It causes cell death, and because of it stops the perfusion and circulation to the retinal area. Hypoxic damage results in proliferation of abnormal new vessels. So when you have hypoxia in those vessels, then, you have a proliferation of these new vessels that are very fragile and prone to leaking and bleeding. So the vessels will start to leak and bleed, leading to a fluid leak in the eye, which causes edema, and we call that macular edema. Right? It leads to reduced vision and even vision loss. There are three main stages. You have the non-proliferative, phase, that stage, that's the early stage, right? It's asymptomatic retinopathy. Blood vessels in the retina develop these microaneurysms that leak fluid, causing swelling, forming exudates. In some cases, macular edema causes distorted vision. Then we have the pre-proliferative stage. We have increased destruction to the retinal blood vessels. Then the proliferative stage, that's the abnormal growth of new blood vessels on the retina. Now, then these new vessels rupture and bleed into the vitreous area, and it blocks light. And ruptured vessels in the vitreous, they form scar tissues, which can pull on and detach the retina, which is very dangerous. So diabetic retinopathy, what are the clinical manifestations? Blurry vision. It's painless. Diabetic retinopathy is not painful. So remember, this one is also painless, just like glaucoma, right? They see floaters. Floaters is one of the identifying signs of diabetic retinopathy, or cobwebs in the visual field. Sudden visual changes, right? It's not gradual like macular degeneration. It's sudden visual changes. Spotty and hazy vision, complete loss of vision. Medical management is glycemic control. We need to help them get their blood sugars in control, blood pressure in control. Smoking cessation if they're smokers, right? Laser treatment helps destroy the leaking vessels, right? Then we have panretinal photocoagulation. It's also a laser procedure. Then we have a vitrectomy where they remove the vitreous humor and replace it with just saline. Then nursing management You want to individualize your care plans based on the patient. Education about prevention through regular eye exams. We want to always encourage them. Control your blood pressure, control your blood sugars, get regular eye exams so it can be diagnosed early and treated, right? If vision loss, the patient has already lost their vision, then assist the patient to adjust to impaired vision, any adaptive devices they might need, diabetes self-care, and how to, perform their activities of daily living. That is it for your eye disorders. Please go ahead and, make sure your guided notes are filled out and review them before class, and I will see you there.